Good morning. This is Dr. Gary Greenswag from the Physician Enterprise at Common Spirit Health. Welcome, and thank you to all of you who are participating with us this morning and to our panel, which we will introduce in just a moment. We are at the end of February, March 1st today. February has been Heart Month, and this is our third in a series of CME grand rounds related to congestive heart failure. And this morning, our focus will be non-medical approaches to heart disease. We are privileged to have a wonderful group of speakers and panelists this morning. And Dr. Selma Mohammed was here a couple of weeks ago for grand rounds with us and has been kind enough to return again. She is currently an advanced heart failure transplant cardiologist, a clinical researcher, and associate professor at the Creighton University School of Medicine at the Omaha campus. Dr. Kenneth Liao is the chief of the Division of Cardiothoracic Transplantation and Circulatory Support at the Baylor College of Medicine and chief cardiothoracic transplantation and mechanical circulatory support at the Baylor St. Luke's Medical Center. He's the program director of the Baylor College of Medicine Texas Heart Institute Cardiothoracic Transplantation Fellowship and Baylor College of Medicine Minimally Invasive Cardiac Surgery Fellowship. Next, we have Dr. Andrew Civitello, who will also moderate our panel, is the medical director of the Heart Transplant Program at the Baylor St. Luke's Medical Center, co-director of the Advanced Heart Failure Center of Excellence, and program director for the Advanced Heart Failure and Transplant Cardiology Fellowship at the Baylor College of Medicine. And last but not least, Dr. Alexis Shafi, who is a cardiothoracic surgeon with experience in thoracic transplantation and adult cardiac surgery. His clinical focus includes thoracic organ failure, heart and lung transplantation, as well as implantation of mechanical circulatory support devices. He is the surgical director of the Heart Transplant Program at Baylor St. Luke's Medical Center. So we have quite the panel this morning, and we're looking forward to hearing from you. So, Dr. Mohammed, we are going to turn this over to you.
Thank you so much for having us today, Dr. Greenswag. I'm going to share my screen here. All right. Good morning, everyone. I have no relevant disclosures. The objectives of this talk are to recognize the appropriate timing for referral of patients with advanced heart failure for percutaneous or surgical interventions, understand indications, contraindications for heart failure patients requiring advanced therapies such as transplantation or mechanical circulatory support, recognize the current advanced non-medical therapy available for heart failure patients, and anticipate future advancement in non-medical therapy on the brink of mainstream. Okay, so before we delve into the talk today, I want to take a 10,000-foot view looking into the scope of heart failure. So heart failure is classified into stages as we discussed last time. Stage A, at risk, and this is approximately a third of the US population. Stage B, patients with pre-heart failure, i.e. those with structural function abnormalities of the heart or elevation of the cardiac biomarker, and this constitutes approximately a third to a quarter of the US population. Stage C, which is classic heart failure, these are patients manifesting symptoms and or sign or have manifested symptoms or signs of heart failure. And this is about 6.7 million adult Americans, and is projected to be about 8 million adult Americans in the year 2030. And stage D, or advanced heart failure, these are the sickest patients with heart failure. Those are patients who have not responded to conventional medical device therapies and need advanced therapies. So the focus of the talk today is going to be primarily on stage C with persistent symptoms and stage D heart failure. We talked last time about guideline-directed medical therapies for heart failure and up-titration of medication. In this slide, putting everything together as far as our approach to heart failure therapies was a foundation on the left with the quadruple therapy for heart failure with reduced ejection fraction, and moving on to titration in step 2 and consideration of additional therapies in step 3. So for patients who have not improved in response to these therapies or have persistent heart failure, then step 4, there are additional medical and device therapies. Specific to device therapies, we have implantable cardioverter defibrillators or ICDs. We also have cardiac resynchronization therapy. There are also additional non-medical therapies for these patients. And at the end of this talk, my colleague, Dr. Liao, is going to talk to you about patients who progress to stage D and discuss mechanical circulatory support, heart transplantation. There are also palliative options that could be offered to patients with stage D heart failure. All right, so let's talk about ICDs and CRT devices. ICD therapy is life-saving for patients who have heart failure that's ischemic or non-ischemic with an LVEF less than or equal 35% and NYHA class 2 to 3 symptoms. And this therapy has a high economic value. It's very important that this therapy offered to patients who qualify for it. Cardiac resynchronization therapy is indicated for patients who have an LV ejection fraction less than or equal 35% in sinus rhythm with a wide left bundle branch block, and they have NYHA class 2 to 3. It improves symptoms, decreases mortality, and decreases heart failure hospitalization. Similarly, it has a high economic value in heart failure. In addition to that, obviously, surgical revascularization for patients who have coronary artery disease is important, and it does improve outcome in long-term follow-up from the landmark trial, STITCH trial. Patients who remain symptomatic despite optimization of GDMT and basic device therapy, such as cardiac resynchronization therapy, as well as revascularization, they may be candidates for additional therapy, such as those patients who develop severe functional mitral valve regurgitation from heart failure. So these patients may be candidates for transcatheter edge-to-edge mitral valve repair, which has revolutionized the treatment for functional mitral valve regurgitation in this sick population. So we'll talk a little bit about what that entails. So this is actually a very neat and novel therapy that was tested in the COAP trial, first published in 2018, and it basically mimicked surgical stitching of the mitral valve shown on the figure in the left, figure A, the Alfieri stitch. Instead of having this through open heart surgery, this clip or device could be advanced percutaneously without significant mortality or morbidity for this population. And it has been shown to decrease heart failure hospitalization significantly. So this is a 60-month follow-up from the trial with a KM curve on the top showing a hazard ratio of 0.5, i.e. 50% reduction over that follow-up period. It also decreased hospitalization, mortality. However, you could see the difference in mortality was not as remarkable as the decrease in heart failure hospitalization. What about patients who remain refractory to these therapies? So these are patients who have stage D heart failure with no improvement despite all of these interventions. So these are patients we should think more about them because they have very high event rate, high risk of mortality, morbidity, and poor quality of life. So defining advanced heart failure is not straightforward. The emphasis in the definition of advanced heart failure is a persistence of signs and symptoms, presence of congestion, and impaired exercise capacity and quality of life that is explained by heart failure, and there is significant cardiac dysfunction that support this definition. We all focus on left ventricular ejection fraction. It is important, but left ventricular ejection fraction is not end all be all. There are patients who have advanced heart failure and need for transplantation who may have normal left ventricular ejection fraction, although the vast majority of patients have low ejection fraction. So it's important to focus on the patient signs, symptoms, the severe cardiac dysfunction, and congestion or hospitalization. There is a mnemonic that helps us identify patients who may have advanced heart failure, and it incorporates different variables. Some of them are clinical presentations such as NYHA functional class. Some of them are biomarkers such as natriuretic peptides. Some of them utilization of medications such as inotropes or de-escalation of guideline-directed medical therapies because of hypotension. So these are things you could just use to identify patients who have or who may have advanced heart failure. And when we see a patient who is developing advanced heart failure despite optimization of all the therapies that we talked about, it's very crucial that these patients get referred in a timely manner for advanced heart failure therapy centers for consideration of additional therapies. And there's a golden window of opportunity for these patients to receive timely advanced therapies and achieve optimal outcome. So if referral is too late, patients may not be candidates for these therapies, and they may be detrimental to them because these patients have already developed significant end organ dysfunction, cardiac cachexia, or malnutrition. So it's extremely important that the patients are referred within their golden window. And if there's any concern, early referral is also acceptable for patients who have persistent heart failure symptoms. I'll talk a little bit about the indications and the contraindications. The indications, it's basically end-stage heart failure. This could manifest as cardiogenic shock due to an irreversible etiology, and recovery is not anticipated because some cases of cardiogenic shock, recovery is anticipated. It could also be chronic NYHA functional class 3 to 4 symptoms, poor prognosis, such as what we described in the previous slides, and this is despite optimization of everything. There are some objective measures that we could use, such as cardiopulmonary exercise testing and peak oxygen consumption or right heart catheterization to help us make a decision about these patients' eligibility for advanced therapies. But broadly speaking, it's end-stage heart failure refractory to conventional medical and device therapies. Contraindication, there is overlap between the contraindications for left ventricular assist device and heart transplantation. There are absolute and relative contraindication, and this has to do with the benefit of these therapies for a given patient. So if a patient had end-stage organ dysfunction, that's going to significantly limit their benefit and will increase the risk of undergoing these therapies. There are also relative contraindications such as age, malignancy, substance abuse, social support, etc. In addition to that, heart transplant has specific contraindications to it, such as severe pulmonary disease, fixed pulmonary hypertension, malignancies that's not curable or high risk of recurrence, or a high-grade malignancy. Some malignancies could be exception if they are low-grade. Obesity that's greater than class 2, active substance abuse, active systemic infection. Age is a relative contraindication. It just depends on the patient overall. Diabetes or non-revascularizable disease. So putting everything together, heart failure is a progressive disease. When added to GDMT device therapies such as cardiac resynchronization therapy and edge-to-edge mitral valve repair, improve outcomes of patients with heart failure. And stage D heart failure is defined as severe and persistent symptoms and recurrent hospitalizations or congestion despite attempts to optimize guideline-directed medical therapy. Early identification and referral of patients with stage D heart failure is key to optimal outcomes. All right, I'll hand it over to Dr. Liao. Thank you so much.
Thank you.
Okay, good morning. Thank you, Dr. Mohammed. It's great presentation that will make my life much easier for my next presentation. So I'm a cardiac surgeon and from Texas Heart Institute, Baylor College of Medicine, St. Luke's Hospital. So my topic is surgical solutions for end-stage congestive heart failure, while focus on the surgical options, i.e. mechanical circulatory support device and heart transplantation. As Dr. Mohammed mentioned, the advanced stage heart failure has a very poor outcome. As you can see, actually is worse than most of the malignancies, and as regard to survival at 1 year. And that the typical therapy for the surgical solution, and when you have a discussion with the surgeon, is when the patient developed NIHA heart failure stage 4 for sure, but sometimes stage 3B patient also needs to have this option as well. And then with regard to mechanical assist device, there's two options. One is for bridge to transplantation. The other one is destination therapy. Nowadays, we see more and more patients requiring destination therapy due to multiple comorbidities and the lack of organ transplant solutions or choices, and a variety of other medical reasons that the patient is not a transplant candidate, and the LVAD can be the destination therapy. The transplant was first performed by Dr. Christian Bernard from South Africa. And then this turned out to be, and initially the patient transplant patient has been struggled due to immunosuppressant challenges. But in recent years, with improved immunosuppressant, the transplant outcome has been improving and has been accepted as the gold standard for end-stage heart failure treatment. The other option, and then which is when the transplant is not available, and then we need to have mechanical support of the heart or total replacement of the heart, that is total artificial organ in this slice. And this is Dr. Cooley at the Texas Heart Institute performed the first total artificial heart implantation and to replace the patient's failed heart. That was in 1969 and at the Texas Heart Institute. So this is the division of our division, and it's founded by Dr. Bart Fraser, who is a pioneer surgeon and pioneer in the field of mechanical circulatory support. Almost all the mechanical circulatory support device, and was developed, tested, and tried by his lab and by his group over the years. So all these devices went through our lab here to get it finally to the clinical practice. As you can see, there's so many devices that have been used over at the Baylor St. Luke's Medical Center, and totally we implanted over 1,600 mechanical circulatory support devices. As you can see, this shows you the history of all the devices that went through our lab and went through the clinical practice. And then finally now, at this stage, this is one of the LVAD is still in the market, working well. That's the HeartMate 3 and here. And then this total artificial heart, unfortunately, even though it's working, but it's too difficult, too cumbersome to use, too big for a lot of patients. So we are looking for a solution now in this in our division that was pioneered by Dr. Fraser and Dr. Billy Cohn. That over here we developed a total artificial heart that's called Bivacol. This is a totally different support mechanism. The old total artificial heart is a pneumatic pump and with multiple mechanical valves to guide the direction. This is a pulseless device, and it's a magnetically suspended levitated technology, and without valves. So durability is supposed to be lasting forever. And then recently, this device just get a FDA approval for the clinical use. So very soon, then you'll be able to see this device coming into clinical practice. If you have any patients that need a total, has biventricular failure and need a total artificial heart transplantation, and certainly you can consider sending to us. And then we are one of the very few centers in the country that have the access to perform such a high impact surgery for total artificial heart. What is the LVAD? I want to give you the audience visual perspective about the LVAD have been talked about for so many years, and give you an idea how this LVAD was supporting the heart. As you can see in these slides, in the LVAD, especially the implantable LVAD, there is always the inflow cannula inserted into the left ventricular apex. That LVAD drains the blood through the pump, and then through this pump. This is first generation of the HeartMate XVE pump, HeartMate 1 pump. This is a pneumatically driven system and connected to the external drive line, external cable to the energy, the power, and also has a carry-on battery, and then it pumps the blood to the ascending aorta, to the ascending aorta, and above the aortic valve. As you can see, this basically this LVAD is draining the blood away from the LV and pumping blood to the aorta directly to bypass the LV to reduce the workload on the left ventricle. And then by the types of how do we divide or differentiate different VADs, but then generally speaking, the LVAD has been grouped according to the mechanical mechanisms. The first generation is also called volume displacement pumps, and typically is a large volume pump, LVAD, and has been working well in the past, and the Pulsatile pump, but because the volume is too big, the size is too big, most patients won't be able to have enough space to get it implanted. And also there's a durability issue. The pump typically only lasts about a year and a half. That made the development of second generation that's called axial flow pump. And this pump actually, some of them has been working very well, and especially for HeartMate 2, and then the longest support with that pump can be at over 10 years. But unfortunately, this type of pump has a higher incidence of pump thrombosis, and eventually was replaced by the centrifugal pump. And that's what we call third generation pump. That's the pump we're using now. And the only pump that is available now is HeartMate 3. Is the centrifugal pump that works very well. And I will talk a little bit about the 5-year performance of this pump. And this pump is approved for both for the bridge to heart transplantation support as well as for destination therapy. As you can see, these 3 pumps inside view. One, this is the XVE first generation large volume device, and then with a big housing unit that pumps the blood away from the pump that generates positive flow. This second one is axial flow, is an impeller that's high speed spinning. The problem with this impeller tend to form the clot and inside the pump. And the third one is the magnetically suspended levitated pump that without contact point of the blood and then the mechanics, so that this device is supposed to last durability is supposed to be over 10 years at least. And also because of the improved design of the mechanics, the durability or the side effect of complications related to prior LVAD has reduced significantly. As you can see, this the history evolution of the HeartMate LVAD, and the first one was implanted in 1998. The second device was implanted in 2008. The HeartMate 3, the recent one, it was implanted first was 2017. Now we have over 5 years data of this new valve performance. And this is just historical reference importance of this rematch trial. That first time is a large randomized clinical trial comparing the LVAD with the optimal medical management of end-stage heart failure. So in this study, that clearly showed the optimal medical therapy is inferior to the LVAD support with regard to survival at the first year and the second year. So because of this study, the device LVAD ever since received FDA approval for the end-stage heart failure treatment as bridge transplant and also for destination therapy. But the first generation device, you can see how big it is. It requires a chest and abdomen combined incision in order to put the pump in. That's the second generation is much smaller and improved, but this is the hardware, the third generation. But this pump, even though with a small size pump, but because of small size pump, there's higher incidence of pump thrombosis. Eventually, this device was replaced by HeartMate 3. As you can see, the LVAD related complications typically have the following 5 complications. That plays an important role in the management, post-LVAD implantation management of those patients. The first one is identify pump thrombosis. Fortunately, the current LVAD HeartMate 3 make it very less issue now. And the stroke risk is still there. It is from embolic and the hemorrhagic, but typically it's controlled less than single digit. And then the other one is GI bleeding, and mostly related to platelet dysfunction and AVM formation. Occasionally, when the pump thrombosis is forming, then there's a hemolysis. And then finally, driveline infection is still a challenging problem. And then we are still trying to find ways to treat or get rid of the driveline infection. So that this is the most recent HeartMate 3 LVAD, and then there's an improved design feature that made it possible to reduce all the complications. The main advantage of this device is fully magnetic, is levitated, that has minimal shearing force on the blood component, a large pump gap, and then that also can reduce the injury on the blood components. And also this pump can create the artificial pulse that mimic the human pulses, that also improves the organ function and especially reduce the GI bleeding, the mucosa AVM formation in the GI tract. So I want to just show you this 5-year data performance of this HeartMate 3 momentum trial and data. This is a multi-institutional trial, and then one of the largest one, and that comparing mechanical circulatory support performance. I was in this trial as well, and then so as you can see, this is time point of the enrollment, and it takes about 5 years to get everything is completed and to get the data. So the principal objective of the Momentum 3 5-year study is whether this LVAD is superior to the previous one, and whether the survival or the risk of complications of old LVAD is reduced or not. And then the 5-year survival, that's another obvious primary endpoint, and the side effects as well. So this is the randomization. As you can see in this slides, compared to the HeartMate 3 prior generation LVAD, this HeartMate 3 has a better superior performance, especially 5-year survival is 58%. That's near the some of the high-risk transplant patient. The mean survival exceeded 5 years. It's very exciting for the LVAD, and then the best one ever has been used in the history. The study conclusion made it very clear this heart ministry is superior to old generation of LVAD, and the survival rate is high and exceeded 5 years. And then because of the study finding, then this is the LVAD has been listed as classified 1A indication for the mechanical support for the end-stage heart failure patient. And compared to the 5 years, it's because of the 5-year survival is always near 60% compared to the optimal medical management. The survival is only 9 months. So clearly mechanical support indication should be always there as a treatment for patients, for end-stage heart failure patient. And then for certain survival of this high-risk patient, even for the transplant patient, and then generally speaking, we are talking about 70% 5-year survival for heart transplant patient. But for those high-risk patients then with multiple comorbidities, and the heart transplant survival rate at 5 years is about 60%. In other words, this LVAD can function or can achieve the similar survival compared in those patients who has high-risk comorbidities for heart transplantation. Just keeping in mind that the LVAD in those group of patients are a good choice alternative to the transplant. So how do we do surgery? And the surgery is very straightforward. Put the patient on heart-lung machine, take a piece of myocardium out, and from the LV apex, and sew the annular inflow cannulation fixation ring onto the apex, and then put the fill in, and then insert this heart ministry pump directly into the LV. There's a locking device here. Just lock this in place. As you can see, this device is inserted and locked in. And then you can see once it's lowered, the pump is lowered inside the pericardial space. And sometimes we open the pericardial sac to allow it laying outside, but most of the LVAD, the pump can be sitting into the pericardial space, and this is how the graft looks like. So at the end, the LVAD is positioned like this, and the outflow graft is reaching the ascending aorta. The drive line is coming out through the upper abdominal incision. So just want briefly talk about this new concept, the total artificial heart, and the idea comes from these two surgeons in our division, and because of the total artificial heart was too big, and the old technology, it doesn't give us enough durability. They thought about using the non-pulsatile biventricular assist device to support the patient, and then this is clinical use, and then the further advanced thought about why not put two heart ministry together to make a total artificial heart. One side support the LV, the other one support the RV. And then that's why this total artificial heart, the bivocal come out. And then you see the newer pump, total artificial heart, is much smaller than this, the old total artificial heart. That's a huge difference. This can basically apply to provide over 10 liters of cardiac output and can fit in anybody's chest. So let's talk about the quick question about the transplant. And one thing, there's something new happening in this field, that is the DCD donor can be used for heart transplantation. And as you can see, there's an increasing organ shortage in heart transplant. And nowadays, besides conventional brain death donation, and then we also accept the patient who donate up circulatory death, meaning those patients who have neurological dysfunction, and they can restore the support in the OR, and then when the heart stops, and we'll take out the heart and use it for transplantation. So we need a special device to do that in order to make it happen and make sure that once we take out the heart is moving. That's called the heart in the box, ex vivo, and heart perfusion device. We take heart out and then reperfuse the heart, and the heart reanimated outside to allow us to assess the function and also metabolize until we're sure patient is good and the donor is good for heart transplantation. Just want to show you a recent case we did here with DCD heart transplantation. This is the donor heart, quickly open the chest, take out the heart, and then we mounted the heart onto the cannula so that we can mount it onto the machine. And then this is how we mount it on the machine as an ex vivo pump to reanimate the heart. As you can see, quickly mount it on. We make sure that the orientation of the pump, the cannula is in place, and then started to massage the heart. And then we put a pacemaker on, pacing these on. The heart rate is still very slow, so we can put a temporary pacing wire to start the jumpstart heart. And gradually, with increased time of perfusion, the heart started to pumping. And so you always want to see with time the heart started to move in, and typically get stronger and stronger. Okay. So once the heart is paced, and with prolonged perfusion, the heart getting stronger. As you can see, it's getting more rigorous, regulated. Yep. And then so this is after about 15, 20 minutes perfusion, the heart looks much better now. And then so we're ready to pack the heart and then send the heart to the recipient side. The heart is then wrapped in the sterilized box, and then head to the external monitor. We can monitor the heart, and during the en route, during the even on the plane, we can check on the heart all the time to make sure heart is working, and check all the parameters and including pacing and the flow and the electrolytes and the lactate. And then once it's done, we came to the recipient hospital, and then recipient that heart is that the chest is open. We reassess the donor heart, and it looks very good. And then we then transplant the heart. So this is very exciting, and with this technology, then we're able to improve potential donor heart by 20 to 30%. So in the future, that you'll probably see more and more donors, the recipients get the donors from DCD heart transplant. So at the end, I was asked to give a question. I'll just ask a question that here is 69-year-old patient who had the previous coronary artery bypass grafting surgery and mitral valve surgery, 2 surgeries in the past, now developed end-stage congestive heart failure and inotropic dependent, and other organ functions are good, and good social support, and then adequate insurance. Would you consider this patient and for LVAD or heart transplant? Is that the previous multiple surgeries are contraindication for the LVAD or for heart transplant? So this is my questions for the audience, and you can let us know at the end of the discussion. Thank you for listening to our discussion.
Dr. Mohammed, Dr. Liao, thank you for 2 wonderful discussions. I think that, the data is very clear that guideline-directed medical therapy in heart failure improves quality of life and survival. And I think on the other extreme, it's very clear that transplant and LVAD improve quality of life and survival in patients with end-stage heart failure. And I think that one of the challenges for the group that takes care of these folks in the clinics is deciding when you're making that transition, because if we wait until these patients end up in the ICU with cardiogenic shock, it's often too late. So I was hoping maybe we could explore, when people are transitioning from medical therapy and device therapy, i.e. ICDs and biventricular pacing, to advanced therapies. And I know, Dr. Mohammed, you kind of alluded to the I need help acronym. I was wondering if you could just give the audience just a couple of sentences of advice about when they might think about advanced heart failure therapies?
Yeah, absolutely, Dr. Civitello. So if your patient is developing hypotension, or if they're telling you that they have advanced symptoms of heart failure, exercise intolerance, fatigue, if you can't up-titrate their medication, if they're requiring more diuretics for congestion. So mostly listening to clinical cues from the patient that they're giving you that they're not doing well, and they just keep coming back, or they keep getting admitted to the hospital, and you can't optimize them. I think this is a clue that something else is going on, which is most likely worsening of their heart failure.
Thank you. Thank you. I would also, just point out to the audience, if there's any question at all, that there's no such thing as too early of a referral to a heart failure clinic or a heart failure specialist. So clearly you can refer them too late, but you can never refer them too early. Had a question for Doctors Shafi and Dr. Liao with regards to ischemic cardiomyopathy and revascularization. I know that topic came up a little bit, and there was allusion to the Stitch trial, and I'm just wondering where revascularization fits in, and if you could give maybe the audience some advice about when you might send a patient for revascularization versus an advanced heart failure center that could talk about revascularization versus MCS versus transplant.
Sure. Yeah, that's one surgical modality to treat patients aside from mechanical support or transplant. I think if a patient has a low ejection fraction, the big question is the myocardium hibernating? Is it viable myocardium? And so there's various tests such as PET scan, MRI, that can give us clues as to whether or not we think that myocardium is hibernating. And when we do identify hibernating myocardium and the heart has not become dilated, severely dilated, those patients can be candidates for whether high-risk PCI or surgical revascularization. We can also utilize temporary support devices to get them through the initial rocky course or the risks of the procedure itself while that hibernating myocardium recovers.
Thank you. I'm going to transition to Dr. Mohammed for a minute, but I would ask the audience if there are any questions, especially with regards to barriers to referral and things that we can help you with. I'd love to hear about it. Dr. Mohammed, you mentioned mitral valve regurgitation and transcatheter edge-to-edge repair. And, a lot of patients with, stage C and stage D heart failure have functional MR. And I was wondering if you could comment about medical therapy and timing of edge-to-edge repair for functional MR.
Absolutely. So as we emphasized earlier, medical therapy is a foundation for treatment of heart failure patients because their mitral valve regurgitation can improve significantly just by optimizing their medical therapy, achieving normal rhythm if they have atrial fibrillation, controlling their blood pressure, controlling their volume. So there are so many variables that could be done medically to decrease the severity of mitral valve regurgitation. If despite this, they do progress to mitral valve regurgitation, then having device therapy improves survival and decrease heart failure hospitalization. But the guidelines are very clear that it's actually class 1 to optimize medical therapy before proceeding with mitral valve intervention.
Very good. Dr. Liao had a patient recently that was referred from our county hospital with severe MR, and after a couple of months of optimization of medical therapy, the MR now is just a trace. So definitely want to try to optimize the medical therapy. Dr. Liao, Dr. Shafi, if you have a patient that's referred in, a young patient that is, doesn't have any clear contraindications to transplant, can you walk us through how you decide if that patient is going to be teed up for an immediate transplantation, or if you're going to try to bridge that patient with an LVAD to a transplant? What is the current thought about that?
I'll ask Dr. Shafi to talk. I've talked enough. Dr. Xavier has a lot of experience in dealing with this kind of dilemma and choices, options. There are a lot of options out there. I will let Dr. Xavier take over.
Okay, sure. Well, I think one, we need to know whether the heart failure is left-sided or biventricular heart failure. You know, many patients present late, and the left-sided heart failure has caused consequences to the lung, the pulmonary vasculature, and has led to right heart failure. So if you've got biventricular failure, your best option is to do a heart transplant. Now, if it's a young patient, there's also quality of life issues that many patients need to be aware of when they make this decision. It's not necessarily you're only an option for heart transplant or LVAD. Patients have a choice in some circumstances, and if a patient has to live with an LVAD, there is a quality of life issue for those patients, taking care of the driveline, being on anticoagulants, whereas having a heart transplant, in many cases, is much easier to manage. So I want to know what the patient's preference is. And then the age range, you say young patient, are we talking about 40? Are we talking about 20? And those are different things, because heart transplant survival is not, it's not a one-time thing where you do a heart transplant and you live the rest of your life till you're 70 with a heart transplant. If you get a heart transplant when you're 20, that survival, that allograft is only going to be 15 years, potentially 10 years. So now you've got a patient who's 35 who needs a retransplant, right? So there may be some utility in a 20-year-old patient of putting a heart pump in, letting them live with the heart pump for 5 years, and then you transition to a heart transplant. There's a lot of factors that go into that decision. Now, if you're 50 years old, which many people still consider to be young, I think going straight to heart transplant and getting that patient to 65 years old is a very worthwhile thing for the patient. So I would want to know more about the age of the patient.
So I would agree with Dr. Xavier's assessment generally, but I also want to mention that the surgical options nowadays there's probably way better than the old days. And then either patient, like a younger patient, either they decided to take a mechanical support route or transplant route, we can always have options to multiple redos. And now in the old days, I remember the most LVAD have done is 5th LVAD. That's in the old days with HeartMate XD. It keeps come back every year, every 18 months, and we keep exchange out. And then by the time we have HeartMate 2 come out, and then we change it out, and the patient live longer. Now with HeartMate 3, I can imagine that we have give an average right now. We know 5 years is excellent performance, and probably 10 years very reasonable. If it's a young donor, other organ functions fine. The lifestyle is reasonable. He's compliant. He can keep going on and have LVAD, and later if start have complication, give him the option that hey, now you can switch to transplant, or if you want continue the LVAD, we can give another one. Again, for transplant, heart transplant as well, then we have done in our place, and the third time redo heart transplant is still option. So it's not the first time your heart transplant is done, you're out option, you're down for the day. If you're young, you can still have second chance, third chance. So those are the options out there. And then the physicians, the surgeons, and cardiologists should have a thorough discussion with the patient's family, and also talk among the groups based on the institutional experience, expertise, that there are multiple options out there.
Thank you, Dr. Liao.
I have a question. This is Gary Greenswag. Let me just say, this is a fascinating conversation, particularly for people who don't touch it every day. And I think the people on the call really appreciate this conversation. it seems to me that once an LVAD is put in, and frankly, even a transplant, there's a lot of babysitting, a lot of follow-up, a lot of sort of really following that patient. And so what happens to the patient who, or how do you manage the patient who lives in rural Texas or comes to you from Arizona or Montana? It feels like they need to stay close to the mothership to sort of make this work. And so how do you do that?
Yeah, I can take a stab at that. So early after both heart transplant and LVAD, the follow-up is pretty intense. So, we want to see those patients weekly or biweekly for a month or two. So the first 6 months, the first 3 months, we really need them to be at least local or be able to get back and forth to clinic. We have plenty of patients with transplants and LVADs that live very remotely from our center. There are people that we see once a year, and they actually do quite well. For an LVAD, it's nice to have someone, a local cardiologist that's a bit of a champion that maybe knows something about it, can look at the driveline periodically. For a heart transplant, once you get out past a year, really not a whole lot that we need to do from a day-to-day basis. We want to check immunosuppression levels periodically. They need to keep up with things like malignancy screening. They need to take some precautions and stay vaccinated. We bring them in once a year for what we call an annual evaluation, where we do malignancy screening. We look at their allograft, we look at their coronaries, we readjust their immunosuppression, but there's really not a whole lot that we need to do. And many of these LVAD patients do really, really well also. I saw a guy in clinic recently that lives in El Paso, which is an awful long ways away from Houston. And, I see this guy once a year, and he has a local cardiologist that helps him with blood pressure and cholesterol and some other things. And he's doing really, really well. So very intense follow-up for the first couple of months afterwards. After that, we can usually get them back home.
Great.
I would also second that. I think shared models of care, like Dr. Civitello has mentioned. Also important for LVAD is training the local EMTs in the emergency department if they live remote from a transplant or an LVAD center, so that they could handle the emergencies. But I think this speaks for the disparities in rural versus urban areas in location of advanced centers.
Great. Again, thank you so much. This is just eye-opening and I think fascinating for our audience.